All right, good afternoon. My name is Summer Nasser. I am I'm translational director in clinical research and leadership, and I'm going to be hosting your Health Services Research Journal Club this year. We have a whole list of really awesome faculty for the next year, and you can see them all on the website. We already posted from 2025 through 2026 is all uploaded. We will be featuring recent publications. We are pushing for 2024, 2025, but you'll see some throughout 2022 from our top GW faculty at SMHS. And we hope to engage all of you, our scholars, faculty, researchers, clinicians, to help move these forward and integrate and collaborate with our researchers. So please hold those dates. And today we are hosting Dr. Jillian Catalanati. She is the Associate Dean for Clinical Public Health and Population Health Practice. She's also our Vice Chair for Academic Affairs for the Department of Medicine and Professor of Medicine at Health Policy and Management at the George Washington University. Dr. Catalanati joined our faculty in 2008. Since that time, she has taught college students in the public health major, medical students in their preclinical and clinical years, and residents as well as faculty. She's board certified in internal medicine and addiction medicine, and is interested in the intersection between public health and medicine, specifically contemplating what public health and population health knowledge future physicians should have to improve their medical practice and integration within the healthcare and public health infrastructures. She served as the program director for the internal medicine residency program from 2013 to 2021 and co-designed its underserved medicine and public health concentration. In her current role as Associate Dean for Clinical Public Health and Population Health Practice, Dr. Catalanati oversees a faculty who delivers clinical health offered to medical students, residents, and fellows at GW, and has led the expansion of population health teachings into the clinical core collection. So please join me in providing Dr. Catalanati a warm welcome for leading our first Health Services Journal Club for the 2025-2026 year on the manuscript, completion of colonoscopy after positive fecal occult blood testing at a community health center. She'll be reviewing the lessons learned and hopefully we can apply them. And I just also wanted to say a warm welcome to our online audience too. Thank you.
Thank you, Ray.
So one more thing, I brought homemade biscottis. I'm gonna pass them around for everyone. No nuts.
Really important one more thing. Fantastic. Thank you so much for that warm welcome and introduction. And I want to be clear that the reason I put in red lessons learned from a learner-initiated multi-institutional chart review is I don't know about you guys, so I'm an internal medicine physician. And so when I used to go to Journal Club, it was basically like, let's tear apart the tables and what's all terrible about this study. And then I would leave like, should I even think about that study anymore? Because we just tore it to shreds. And then one day, Janice Blanchard in our emergency medicine department invited me to their Journal Club for the health policy section. And it was dinner and wine and conversation about the practical application of the article. And I was like, this just blew my mind about what Journal Club is supposed to feel like. Like it should be, let's think about practical applications of these articles. So when Summer asked me to do this, I thought like, really I can speak to like lessons learned from the practical application of like we tried to do this study, and obviously we'll talk about this too and get to that. But I am completely open to any questions that people have at any point along the way, whether they be about the study, but also just about like the logistics of how we did it or stuff that sort of got in the way of doing it. So for the folks in the room who are not internal medicine physicians, basically the only background information that you need to understand this article is that there are various methods to screen for colon cancer. And you can either do procedural based methods like a colonoscopy or stool based methods. And this is not a picture of the one that we used necessarily in this study, but basically looking for fecal occult blood would be the way that we use it in this study. And the only important thing that you need to know is if you start with a stool based method and you find that that's positive, those people need to then go to colonoscopy. Okay, so it is a fairly common method for folks in resource constrained settings to say this is the much cheaper way to screen for colon cancer is to use a stool based method. So let's do that because all the negatives great, we're done with it. But if we do get positives, we have to shift those people towards getting a colonoscopy, right? So, the way this came up for me, as Summer said, I direct a sort of sub-track of the internal medicine residency program that's called Underserved Medicine and Public Health Track. And this is basically a subset of residents who are interested in caring for patients who come from under-resourced communities in whatever clinical field they want to do. And so this came up because one of our residents in the track, her name is Tatiana Rujeles Suarez. She was rotating at a local community health center that is called Neighborhood Health in Alexandria. If you haven't heard of them, they're actually a great community health center in the area. And she said, "Oh my God, Dr. C, the worst thing is happening at Neighborhood Health. They're using stool-based methods for colon cancer screening." And so we were able to have a really good conversation about how, in fact, let's read the USPSTF guidelines. These are completely appropriate and acceptable methods for colon cancer screening. And then the next time that I saw her, she said, "Oh my God, Dr. C, the worst thing, I realized that when someone has a positive stool-based result, they get referred to UVA. And I feel like Michael knows how far that commute is to go from here to UVA. If you haven't driven that, what, 2.5 hours, roughly? About 2.5 hours to get from here to Charlottesville. But she was obviously then faced with the question of like, how many patients are actually completing this next step? Because that is 2.5 hours. So as my shout out to Tatiana Rujeles, who's here, she said, "I wish that we could start a Go Lightly bus." And that bus would be, people can take the prep for their colonoscopy the night before, they're ready the next morning, they board the bus, and I would drive them to UVA and they would get their colonoscopy. So we called it Go Lightly Bus, and I gave the credit there to Tati. And I said, well, that's probably not going to be the way, that we solve the problem, although that's a creative solution. You'd have to make sure there's a bathroom on the bus, et cetera, to do it. But we came up with the idea to just say, I wonder if Neighborhood Health even knows like how effective is the follow-up for this screening and are patients getting this done or not. So we came up with the idea for this project. And as part of the track, they're required to do some form of a practicum project. And she said, "Oh, I would love for this to be my practicum project, to think of just helping them to figure out how effective actually are they getting colonoscopies after positive fecal occult blood testing that are done there." So I have this map here for people who are less familiar there. That little arrow is Alexandria. So that is where the patients are coming for their primary care. Presumably that is where they live. What Tatiana learned when she spoke to her preceptor was actually one place where people could get referred was Inova Hospital in Fairfax. And actually more of the patients were referred there than to UVA. The other place would be down in Charlottesville at UVA, which is approximately 100 miles from where most people lived, right? So then she started asking, well, what are the different reasons? Like, why would you send someone to UVA when you could send them to Fairfax, right? Which is closer. And what she learned was that Fairfax, even though it was only about 15 miles away, it was much harder to qualify for their financial assistance program. So they have a financial assistance program. The vast majority of patients at this community health center have no insurance, so they don't have Medicaid, they have no coverage at all. So they would apply for the financial assistance. And at Inova, it was actually harder to qualify for that. But the advantage at UVA, even though it was further away, it was actually easier to qualify for their financial assistance programs. So that's actually kind of how they sussed out where to go. So sort of that's where our kind of study was born. So I have some of these awesome slides that look like this that are summer suggestions for discussion, which I think are awesome suggestions. So I hope other people throughout the year will use them too. But again, just for you guys to sort of think about. So given what you've heard so far, and a resident just told you this information, what do you think of how you would sort of approach that? As what's the problem here? What can we address? How do we think about that as something important to us? Any thoughts?
This is hilarious because I actually wrote down the answers to those questions. And I had not.
Clearly, you guys are tight.
We did not conspire.
So what do you guys think?
So I'm not gonna answer because
I was just like, because you pre-thought about it, and other people are thinking on the fly.
For those of you playing along at home, this all means playing along at home too.
Absolutely.
we're gonna cancel the virtual option if you all don't play.
Hi, this is Katie. I'm at home with my 1-year-old who has a fever and a cold. So if you hear random farm noises, that's also us. But I mean, I think one of the big problems here is like an inequity in access to care due to health. Yes, I know it is terrible. Due to a lack of insurance. So, I mean, I think that's one big issue. Even though Inova has tried to apparently fix it, there's still clearly structural problems because everyone knows if you don't have insurance, you're not going to get a colonoscopy at Inova. And I'll stop talking there.
Yeah, so one angle is the straight up access angle as it relates to insurance, right? So we think of if people have Medicaid, perhaps they have more access, but then some people I think like to say, oh, but we have these financial support programs. And so of course we have an alternative pathway, but you don't actually all qualify for the financial support programs. And it's a lot of paperwork to do so, et cetera, right? To do that as well. How about other ones?
Physical access to where they're being referred to, so they're being referred far away, 30 minutes at best, 2 hours at worst, which isn't doable for a lot of people.
Good. And so if you were the folks at Neighborhood Health, if you knew that the UVA ones were not in fact resulting in colonoscopy, maybe you would try and find some closer by partners, right? To do that, to actually achieve that better health outcome for patients if that's truly not happening.
Timely and complete diagnosis of colorectal cancer disease in specific population.
Good. So as a health outcome, we not only have completed screening in these patients, which was the whole thing we were trying to do in the first place, but as a clinician, we're almost in this worse in between area where now we have this one positive test and we have not followed up on that either, right? So it has become like delayed diagnosis potentially, right? In addition to not actually achieving the outcome of having people screened for that too, right? Yeah, perfect.
And what in colon cancer, colon cancer in particular, the screening and diagnostic tool becomes treatment and curative. Right, so you identify a polyp that is precancerous or cancerous, so you remove it, so you treated the person. So it's a one cancer screening tool that become treatment and curative. And so, which is I think why Jill was highlighting why people who have a positive occult blood test, it's not just necessarily urgent to move them to the definitive colonoscopy, because there are other things you can do. You can do a flexible sigmoidoscopy, you can do these other things, but moving them to the more definitive, higher cost intervention is recommended more immediately, because then you can remove the polyp if you see it, and then the person no longer has this precancerous or cancerous.
And it is that difference that, again, we teach our residents the gold standard is colonoscopy, in part because of that reason, that if we actually saw something, we can in fact cure cancer. And that is why our resident was so horrified to see that someone might not receive colonoscopy, right? As step one. There you go. I think what's important too, to this second question, the other audience here is the folks who work at Neighborhood Health. And so as Tatiana started speaking with them about like, hey, I have to do this project, and I was wondering if this is important to you, it actually just so happened that they were starting to think about their own their own colon cancer screening rates and how well they were doing on that as an outcome, which was perfect because they were like, actually, we'd love for you to help us answer that question, because we as an organization are starting to think about that. So that was just great that it aligned nicely with where they happened to be thinking about what they needed to, which was good. So the methods which you guys saw in the article, basically what we did was we took all of the adult patients at just that one community health center, so just Neighborhood Health, which is again, a sample of convenience, right, who we had access to. So looking there, if they had a positive fecal occult blood test that was done basically between 2018 and 2021, you will see from that how long it took us to actually complete this and get it published, when you see the gap between 2021 and when this actually came out. So at the time, 12/31/21 was a pretty timely choice for us to pick that timeframe. And what we then decided to do is we would do chart reviews at the community health center level, so in their electronic record, to see, let's pick up demographics and insurance status for the patient, but let's also look at when did we get the fecal occult blood test result back? Compared to that, when did they get referred for a colonoscopy? When did they actually apply for and receive approval of financial assistance if they applied for that? And then do I see actual colonoscopy results here in the chart? And what we realized as we talked about the project, so this is gonna be one of my first lessons learned. I can't help but notice looking at the faculty that I'm older than a lot of people in the room. So one thing that I've learned is students and residents really like to come to you with projects that they think are tiny, easy, achievable projects. And as you talk to them, you start to realize this is gonna be a pretty big project, right? They were talking about if we do it in that way. So we realized while we were talking, actually, there may not be colonoscopy results on the chart, but that doesn't answer the question, did they get a colonoscopy? We actually need to look at the Inova record and at the UVA record, right? To see was this in fact performed there? So we also decided we would look in the electronic health records of the 2 different sites to which people were referred to see, did they in fact have a colonoscopy? And also, did they have a visit with the gastroenterologist? Because sometimes you may have that visit prior to a colonoscopy, and then just confirming, hey, we found the results, even if we didn't see them in the chart of the electronic health record of the CHC. So we decide that we do that. That adds a level of complexity, right? Because you'll notice that none of these centers are GW. So Jill doesn't have access to any of the charts, right, that are in question. So we'll talk about that and what that added in terms of data use agreements and all that kind of stuff to be able to do the study. But basically, we extracted this information from those 3 EHRs, so whether it was Neighborhood Health's, Inovas, or UVA's, and then on that performed various degrees of descriptive and just descriptive analysis, some chi-squared or t-test analysis, depending on what it is. And then we had Sean Lee here, who might pop in because he said he was going to try and come by after a meeting, who fitted in a logistic model and basically said, let's do stepwise selection to try and figure out what variables most influence the likelihood of someone getting a colonoscopy. And we decided up front that when we did the model selection, if it didn't include distance, we would then also do a second model that included distance. So we sort of decided that from the get-go to do that. So that was our sort of methodology. And I summarized table 1 here just because table 1 was too long for me to reasonably put a picture of it on this slide. So summarizing in table 1 is looking at the number of patients that we had. So there were 130 patients. And it was actually split completely half and half. 65 completed a colonoscopy and 65 did not complete a colonoscopy. And when we looked through the demographic data for them, there was actually no statistically significant differences between those 2 groups of people, which is interesting. This was not randomization. This is just how it happened. And they just happened to not be different groups. So just so that you know who was in there. So a little more than half of the patients were female. By race and ethnicity, this really reflects the clinic that we were working in. So it was about 50% white, about 27% Black, about 10% Asian, 10% other, and about 43% Hispanic. And that really is what the community that sees Neighborhood Health as their primary care source does look like. 42% of them were employed. And the primary language, again, most patients of Neighborhood Health are primarily Spanish speakers. There were about 21% who spoke primarily a language that was not Spanish and not English. And then the rest were English or other speakers. Income, so very low income population of folks. So three quarters of them earned under $2,000 per year. And that is actually in the electronic record for this community health center, because that's how they determine what they qualify for in terms of other things. The majority were uninsured. So 3/4 were uninsured, about 20% had Medicaid, only 3% had Medicare. There, the mean age 60 years. And then when we looked at the mean difference to how far they would have traveled to the colonoscopy site, it was about 30 miles. And that was because actually 3/4 of them were referred to Inova Fairfax. That was the more common referral location compared to the other quarter that were referred to UVA. Questions about that from table 1 in general? Okay, great. That's like your mandatory table 1, right? That you always have to sort of put up and say. So, what were the results that we found when we did this? So the first result was that only 50% of people had a colonoscopy done, right? So as I said, it was 65 out of 130 of them. So, when we think about target setting in population health and how are we doing on the health outcome, that's not such a high goal, right? 50% not so good. But half of them are getting the colonoscopy, the other half just aren't. What I found really mind-blowing was that the gap of time between when you actually had a positive fecal occult blood test result and received the colonoscopy, if you had it done, was about 8 months. So that was a pretty long gap between them. And when we did the reduced logistic regression model, the 2 variables that we found in there that were significant were insurance status and age. Insurance status was the highest contributor to risk. So people who were insured were really twice as likely to get colonoscopies than people who were not insured. And then age, the standard deviation was about 7 years, and every 1 standard deviation increase in age, people were about 41% more likely to get colonoscopy. So I thought that was an interesting finding when you put it together with health insurance, because my mind first was like, of course, because now they're getting Medicare. But no, only 3% of these people had Medicare. So that is actually not the age connection that got more people to get the colonoscopy, which is interesting to think about. And then sort of last finding was, again, distance was not significant in the model. So we then made the second model where we put distance into it. And when we did that, we found an increase of 38 miles to colonoscopy sites. So every 38 miles further that you traveled had about a 17% decrease that you were less likely to complete your colonoscopy. That finding. Make sense in terms of results? Cool. This is just some of the imaging. So if you haven't already realized that you should always partner with an actual statistician to do your work, I feel like this image should demonstrate that to you, because Sean can generate things like this that I cannot generate. But I think this was a really nice way that he presented the data for us. So the sort of pink or red line there is uninsured patients. The blue line is insured patients. And if you look on the left, that's age versus your probability of getting the colonoscopy. And you can see as you increase in age, you're more likely to actually complete the colonoscopy, whether insured or uninsured. Interestingly, the slope is almost the same actually between them. And then if you look here, this is distance traveled. And again, same, the insured patients were significantly more likely than uninsured patients. And you can see that goes down, but it doesn't go down with such a steep slope that I thought it might, right, to do that. So clearly insurance was the biggest impact here, followed by age, and then distance traveled again had some impact on that. Again, hard to know when we're thinking about the ends. There were 130 people and only about a quarter of them were referred to UVA to go the further distance. So, oh my goodness, is there a way that I feel like there is a way to hide those, but I never remember. Okay, so I thought some of the more interesting findings were like some of the more granular stuff of like, how can we, if we are neighborhood health, like make some changes here, right, to try and impact this. So, although 50% of people had their colonoscopy, when you break it down by site, it was about 53% who went to site A, which is Fairfax, and only 40% who went to UVA. So there is a disparity between those two sites with people completing the colonoscopies. The time from the positive fecal occult blood test to colonoscopy referral was a month and a half. So that means like their office had the positive result and somehow it took a month and a half to actually even write the referral for the patient. So that's a potential place of intervention, right? They could do that. And then when we looked at the financial assistance for folks, so the time from initiating that application for financial assistance to getting it approved was 5.5 months. So that's where a lot of the delay came for those patients. And then, as we said, the time for the positive test to the colonoscopy being completed for people who completed it was about 8 months. But interestingly, when you looked at that for insured versus uninsured people, it actually wasn't so different, which I found very surprising. So it was about 7.5 months delay for the people who had insurance and 8 months for people who didn't. So for the people who didn't, again, we can explain some of that delay in here. But for the other folks, they were clearly just waiting for an appointment or having challenges to book the appointment or some other barrier like that, right? They didn't have that 5.5 months delay, but still got their colonoscopy at about the same time. And then again, among the 65 people who did successfully get a colonoscopy, this was on my brain because in 2021, I was the division director for general internal medicine here. And I was actively, whenever I could, talking to our gastroenterologist about why on earth does someone need a GI visit before a colonoscopy? Can't I just send them to you for a colonoscopy, right? So people call that fast track colonoscopy without a gastroenterology visit first. So I was like, we're gonna check if they're doing it over here. And so interestingly, when you looked at the 65 people who did have a colonoscopy, 74% of them actually had a GI visit before. And then we looked at, because we had the GI records, what did they do at the visit? And for 60% of those, all they did at the visit was say, yep, you need a colonoscopy because you had a fecal occult blood test that was positive. So that really, to me, is a wasted visit. All that did was confirm that you had a test that requires a colonoscopy. But in about 40%, they actually addressed something else. Right, and that was various other something else's, but different things that like, okay, you could argue that visit was helpful to you because something else was addressed there besides the positive test. What really made me want to cry was when we looked at the 65 people who did not complete the colonoscopy. I don't know which of them were supposed to have a visit, right? Because most of them did not have a visit. However, 9% of them did in fact go to a gastroenterology visit. And so they made it to the visit, but didn't make it to the colonoscopy. That was after that. And of those, 5 of them out of 6, so that's 6 visits, 5 of them addressed another problem. So cool, that one didn't make me cry, but this patient made me cry. So one patient got to the GI visit, did not get to the colonoscopy afterwards. And I will tell you that this was one of the UVA patients. So this person managed to travel 100 miles to get to that visit, which was an unnecessary visit, and then did not get the colonoscopy afterwards, which was the only purpose. So that was the one participant who I felt very sad and touched, to read about. And then surprisingly, good news, the closed loop communication was fabulous. So I think we have something to learn from ANOVA and UVA. It was shocking. It was
Between our health centers and our EHR.
really, it was so surprising.
I'm sorry, between University Hospital and our EHR.
Exactly. So 94% of the colonoscopies that were done, there was a result that actually made it back to neighborhood health and was there. Of those, almost 98% had the pathology report, which is like, that is gold for primary care doctors to be able to get that pathology report. And then of the ones that had a polyp that was removed and gave you advice, like when should you do a colonoscopy again? Actually, 3/4 of them had that. So this is fantastic in terms of performance of those two organizations. So that was good. But I highlight ones that to me stood out as, hey, these are like pretty like easy, not easy, but straightforward places we could intervene. Right? So we can think about why are we having a delay in the referral. We can think about, can we communicate with the folks to whom we're referring to just get fast track referrals? Clearly there is a way to do it because some patients got fast tracked and other people didn't, right, when they were there. So just kind of things that I highlighted. So, so again, overall conclusions for the study. So as we said, only half of the participants who had a positive fecal occult blood test made it to a colonoscopy, and on average 8 months elapsed between those, which is a long time. Having insurance was the strongest predictor. And again, that's despite the fact that they're being referred to 2 places that do have financial assistance programs. But that still didn't necessarily get people to colonoscopy. Increasing age increased the likelihood of completion. And I would love to hear people's thoughts and guesses as to why that is. My first guess for that is, does that relate to employment status? That maybe as people were getting older and perhaps were retired and didn't also have to take off work to get to the colonoscopy, maybe, but it did not relate to changing insurance status. And traveling longer distances did decrease likelihood of completion. And again, it was about every 38 miles, decreased it by 17%. So not actually as strong a predictor as insurance status or even as age was. And then again, lastly, that there really were some points of intervention that we could really act on after we had this information. So this is another one of Summer's great questions, which I love. So in terms of outcomes or recommendations that could apply either to your own practice or anything or further research, I guess I'll ask the room both if you want to think about this as your own practice, or, okay, we now have this information and I handed it to neighborhood health, right? I did remember that I have to give the results back to my community partner, right? So we did give them to neighborhood health, and then so what? Like, what do you think they can do with this? Or what would we do with this? We got it. Yeah.
Are all polyps cancerous or some benign?
Great question. So actually probably more of them are benign. So some are precancerous, some could be cancerous. The majority are actually benign, but you need to like look anyway because you won't know until you remove them. And that's why the pathology report is so important, because patients will come to a primary care physician and say, oh, I had something removed. And you're like, what was it? You know, and you don't, and you just don't know unless you see the pathology saying, was this cancerous or precancerous, or was this completely benign and it was just a lump? That's what I removed. Yeah. It's a great question.
Curious to know in another population what this data would look like, because I do think that especially for a colonoscopy, it takes a lot of people some time to psych themselves up to do it. So it's not just the like logistics, you need a ride, you need to get there, you're not gonna eat, you've got a holiday, you've got an event, you've got this, you've got childcare, whatever it is. But I think there's like a psyching up time period for a lot of people.
Absolutely. And that was one of our recommendations for further research, was like, actually, if someone wants to do the qualitative study, to interview some of these patients and learn like what truly were your barriers, right? Because they could be so many. You listed so many, they're all.
There's a hand up.
Oh, there's a hand in the room. Leslie, yeah.
Hi, thanks for this. It came up, one of the things is it's not one person taking off of work, it's potentially 2 people taking off of work. Did you look at marital status as one of the variables?
Well, that's such a good question. And we did not look at that. But for people in the room who have not referred to a colonoscopy, that's because you are not allowed to drive yourself home from a colonoscopy. So we sedate you to do it. And because you've been sedated, we're not going to put you in the car with a stranger or let you drive yourself home. So that is a great question. And we did not actually look at that piece of data.
We have.
You have that information, it just might be something to run real quickly.
Not allowed to take public
Transportation.
or
Yeah.
ride share.
Which the Go Lightly bus could drive you home.
Well, I was just saying, I mean, I don't know if we have it currently at this moment, but we did have a patient navigator who, and who could actually help with being the chaperone or finding people that could be the person that went to the appointment with folks. And so that could be a thing to look into, figuring out other resources for transportation, which is tough, but you know, something to invest in. And like you said earlier, thinking about partners that are closer than 100 miles.
Yeah.
Do you, there are several things that cross my mind, but do you know what the actual financial assistance was for the program?
So I believe if you qualified, at UVA, I'm pretty sure you pay nothing, and at Nova, I'm not sure.
Okay.
So.
Do they
So-
provide transportation as
Do you know
part of
the?
it?
Nope, that, so there is a 7x7 grid of resources, and if you're a 1-1, that means you have no resources and no personal resources and no outside source of resources. That's the only screening group that was able to get gratis services
Gotcha.
by the hospital. It's not the question is not the same for the gastroenterologist and their practice. It depended on, So there were also some sort of professional standards questions that depended on, so like if you were having orthopedic surgery that was elective, not treating cancer, they were not seeing, like if you were 1-1, you just weren't getting it done. And that was just their policy.
So there,
Very.
this becomes an interesting, for those of you who do this kind of access to care, research or going to explore this type of research, when you're looking at financial assistance programs, who's providing the financial assistance becomes important for uninsured and underinsured, and it can become part of, or one of the variables that you look at, and could itself be a research question. So for example, when we were looking at, or when they were looking at in their study, this notion of the uninsured versus the insured presenting for colonoscopy and the length of time, that could actually be an impactful variable. So if the financial assistance program actually pays a gastroenterologist for the procedure, and they pay more than the type of insurance that the uninsured have, that can accelerate access for the uninsured. So you see this sometimes in publicly funded financial assistance programs, like for example, Project Wish, which is the breast and cervical cancer program. It actually pays healthcare providers to give people access to breast and cervical cancer screening. So it pays a healthcare provider for mammography services. It doesn't make it like they don't have an organization where people go to like the government to get a mammogram. It actually cuts a check to somebody else at the fee that somebody else says, we will give X number of people a free mammogram. So if that fee is higher than what the actual insurance company pays, that organization is going to take more people who are getting financial assistance. So it's important to try to understand those types of things when you're looking at these variables as to why uninsured people may get a service faster than someone who has insurance, and which types of insurance. Does that make sense? The other things that happen with colorectal cancer in particular is that your insurance pays for different things that when the colonoscopy type changes. So you don't have a copay when it's a screening colonoscopy. You have a copay when it becomes a diagnostic colonoscopy. And that makes people with insurance very nervous if you understand the insurance or if it happens to you once, right? So you go in for a screening in colonoscopy and they said, oh, that's covered. We have to pay for that. You don't have a copay, a deductible, co-insurance, all of the things that nobody really understands unless they do this for a living. And even then, people who work at health insurance companies don't understand half the crap that they make you do. And so then you get a bill because they removed the polyp. And you're like, I thought it was free. Well, it was when it was a screening colonoscopy. But the moment they removed the polyp, it became a diagnostic colonoscopy. And then your co-insurance, deductible, and copays, all those things kicked in. And for a $3,000 procedure and you have a 20% co-insurance, now you've got to pay 20% of $3,000. And if you're retired or shit, you don't have to be any of those things. You can be a full-time regular faculty member at GW and you have to pay 20% of a $3,000 bill that you weren't expecting to get. It becomes a little discouraging to go the next time. So to Leah's point about you got to psych yourself up, not just for the for the prep,
Uh,
but for the potential costs that may occur. And to Jill's point of, you get the recommendation and it's like, sometimes you have to go back in 5 years, sometimes you have to go back in 3 years, sometimes you have to go back in 10 years. You need to understand things. So all of this plays into what variables are you gonna look at in your studies to understand barriers. That's why it's important to have team-based science. So the people on your team can help you understand the clinical processes, the workflows that happen in the clinical environment, and all of those things to design studies.
I also want to note that time difference is significant in terms of outcomes.
Yeah.
And I think that's the question the insurance company is going to ask. So do 3 months make a difference in your outcomes? And if the answer is no, then they're not going to do anything. And if the answer is yes.
That's a very
Yeah.
United States versus most other health systems in the world question, right? And so we in this country routinely bash Canada. It takes too long to get things done, and a small number of Canadians like it takes too long to get things done. The NHS is kind of collapsing in Great Britain right now, and one of the things is that it takes too long to get things done. But it turns out that our colorectal cancer mortality rates are higher than all the countries I mentioned so far, even though it can take a long time between diagnosis and therapeutic intervention. And so, another really huge body of questions that we need to ask and answer as a country, not necessarily as a center of as scholars, is how long is too long for certain diagnoses? Like, I had prostate cancer and I was like, sign me up, let's get this thing out. I'm not trying to advance my stage of prostate cancer. So I had surgery fairly promptly after my diagnosis. I knew people. I knew a guy, actually a gal, that got me right in and took care of it. But the average person, the average user doesn't have that facility to access it. And that's another very important research question. Is, should we be pushing payers? Should systems be pushing payers to that they need to facilitate these other models of payment so that the providers of these services are incentivized to move them up? Or should we be saying, turns out that if you wait 8 months, no one's going to get sicker or have an event? And I don't think that's probably true. I think that's probably not true, but that's an important
But
question.
there's some number of months for which it's true.
Yes.
Yeah.
Rebecca.
I'm actually curious to how will this appointment schedule, were they scheduled as screening colonoscopies or diagnostic, given that they all had positive fit test? And I was honestly surprised by the difference between from the time of a positive fit test to getting this colonoscopy, and I don't know if
I found myself wondering that when you were talking about the payment, and I actually don't know the answer to that. If someone's reason for colonoscopy is another positive screening test, can it still be billed as a screening colonoscopy? And I don't know the answer to that.
I think
I don't think it's.
it must be a diagnostic.
Yeah, I
It's like
think
this happens with prenatal testing too. So, and also
The first positive.
yeah, so I don't know if it'd be advantageous for people to just be referred for
Let's go to
colonoscopy instead of fecal occult blood, because I don't know if it's.
Well,
in
let's
the-
go back
in
to
the skin.
epidemiology, never needed to treat,
Right.
so it's not advantageous to go straight to colonoscopy. Y'all sound like Tatiana.
Well, I mean, in terms of getting it
Financial,
covered
right?
financially, like not.
Yeah.
And
From the
but
insurance company.
morbidity, mortality wise, of course, there are complications, and so you don't, and missing work and all of these things are other issues.
So this is fascinating, and I want to get back to methods and all those things, but I also want to talk about this from an equity perspective. In the question of what's the best screening test to order for your patient, the one they will get, right?
Yeah.
And in these populations,
They'll do.
right, in these populations, I can imagine, and this could be a study, if you did not offer FIT testing or FOBT in your practice, your colorectal screening rates would be low, right? So if we went back to GWMFA and looked at before we were doing FIT and fecal occult blood testing and just colorectal screening. So the KPI is colorectal cancer screening. And there are 4 different types of screening that would qualify for that metric or measure that then combine, right? If you took out the easier to do things, you'd bottom out. Like you'd probably be at 10-15% because FIT and FOBT are all very popular. Now the patient gets to choose. There are some patients who will go directly to colonoscopy. And then there'll be some who are like, send me that kit in the mail. Like, I'm not doing all of that. So if you got rid of that, and we could look at that, I think somebody could just very quickly look at what percentage of our patients do colonoscopy first versus do FIT or FOBT first. And you will see that and I know what the answer is, but you will see that the majority of our patients do not opt for colonoscopy first. And so we took those options away, regardless of paying for it, et cetera. We would see a widening gulf of our inequities for colorectal cancer screening.
And to your point of like, so this study, we excluded people who had a negative fecal occult blood test, but there were only 130 people in 3 years who had a positive. Right, and it's not because they're not screening anybody for colon cancer, right? It's because actually the vast majority of these are negative. Sorry.
And so Rebecca is on the screen. So
Yes, Rebecca, go ahead. We see you.
Hi, I'm Rebecca, and as a laboratorian, I love this discussion. I think this was a great paper. I actually have two questions. So the first one is for your table 1, were you able to get all that information from your patients? And if you couldn't, like for example, incomplete charts, how did you deal with that? And then the second question is, how did you figure out to stop your study at 130 patients? Like, was this just from the time period or was this from a power analysis? Because I'm trying to understand how relevant of these logistic models are if, let's say, this patient population wasn't big enough to make those conclusions.
Yep, those are two great questions. So I will say that I think to your second question about power analysis, when we started this project, we were not thinking, oh, we're going to publish about this project. We were initially just thinking, oh, great, you have a practical project to do, and this might be useful for neighborhood health to do that. So we did not do a power analysis, which we should have done, because that would have told us, right? We could have said roughly what's the percent of people who have a positive fecal occult blood test, therefore how many years do we have to do that? What we did instead, because we weren't initially thinking about that, was let's pick a time period that's going to be a long enough time period where we feel like we will get a reasonable number of referrals to UVA and to ANOVA. And what we did really was we just asked the clinicians who work there. So that is bad statistics from like an approach perspective. For a practicality perspective, you know, we definitely leaned on the people who worked there to say, like, what do you think is a reasonable time frame in which you guys are getting enough of these tests? We were lucky that when we then had our discussion with Sean, who did our stats, he said, like, okay, I can make some reasonable conclusions from this, and this is good. But that is also why, as you saw some of the other information that I presented, our N was just too small to even test for like statistical significance on a lot of those other things. It just wouldn't make sense to do that. So that is the challenge. And frankly, if when you get to the step of like, if you want to publish your work, if you have not thought about that first, right, which we did, I mean, we thought about it in the census to get IRB approval, but not in the sense to really do the strong power analysis and everything, then you find yourself thinking, where can such a small study at just one institution that obviously has limits on its generalizability, where is that of interest and where can that be published, right? And so you have to do things like make sure you're phrasing it as a pilot study, as a first step in research that needs further research to back it up, which this for sure does, right? Given how small it is and the fact that it was just one community health center, for sure. And if it's a helpful tip for you, one thing that I think about if you find yourself in a scenario like that, when you're submitting to a journal, you know, they're going to have the type of research that they call like the research that gives you 3,000 words, whatever they call that original research. And then they're going to have the ones they call like brief report or like letter about research or whatever it is, which gives you 700 words or 1,000. And I think you need to be reasonable about the limitations of your own work to say, okay, this is a one institution study that only looked at 3 years of data and has a small N, like no one should give me 3,000 words of their journal or this, right? And I think you need to know that when you're submitting that too. Yeah.
Addison.
I was just curious, from the clinic's perspective, if they had looked into, because it was blowing my mind, like the difference between insured and uninsured people not being that big. So is it that they just have like exchange insurance that isn't very generous, and so they're still relying on these benefit programs? Because like, why would you go to UVA from Alexandria if you're insured? That was kind of like I guess did the clinic look into that or what was?
Listen, when I first got here, it took 8 months to get a colonoscopy from GW. When I first got here. Listen, that was the other thing I was gonna say, 8 months, that was our wait time for primary
Which is why the
care.
insured folks still had 7.5 months.
Right, for primary care here to refer patients to a GI doc here, which is probably why Jill was on the phone talking about it's a waste of an appointment for them to come. Just stay in the colonoscopy suite. Okay, just stay in the GI suite. Just right. Just form a line, people, form a line. So I mean, it was literally 8 months. And I called for an appointment and it was like, say what now? And I just went back to my GI doc in Howard County. So I mean, it was just 8 months and I got in them within like 3.5 weeks. So academic medical centers can take that long to get into a GI doc, whereas these smaller GI practice groups can be a lot faster.
And the other barrier is because of who this patient population was, the people who had insurance had Medicaid. Right. So they still had limitations on their access to who would actually accept that.
Yeah, and reminder that UVA is one of the 2 that I'm aware of public hospitals in Virginia. VCU being the other one. So there's only 2 public hospitals that have an obligation from the state to actually take, and in some cases, all payers, including no payer patients. Nobody else does. Certainly, Nova absolutely does not. So their community benefit, and that's part of their community benefit as a not-for-profit. But they get to sort of manage how that is deployed.
That's why they have, it's harder to qualify.
When I was still there, we were the catch-all, and I had many patients who came for me for elective hernia repair from this part of Virginia, because we would take their insurance or lack of insurance. The other question, and then you had a question that I have for you is, I remember reading in the paper, you guys talked about the percentage of undocumented versus documented. It didn't end up being impactful in data. Is that right? If I remember that, the PI was negligible.
Yeah, so and I can't remember exactly what it was when we used it, but yes, correct. The neighborhood health population of, so one thing that I think is very interesting as a clinician who practices in DC is you don't have to go very far over the border into Virginia to just see completely different scenarios in terms of how many people are uninsured and the different populations that live there compared to who we see here at Foggy Bottom. And so it's a great example of that. And as you could see, only 20% of these people qualified for Medicaid, despite the majority of them earning less than $2,000 a year, right? And so the reason why most did not qualify was because they were not citizen permanent residents. Yeah. And that's also why the Medicare number was quite low also, despite some of the over 65. Oh, I'm sorry, Suzanne, that's I'm sorry.
Yeah, so that's kind of where I was going with it. You had almost 50% Hispanic population, which I see as a treasure chest of knowledge of qualitative data. Like, why? That's patient centered. Why did they not follow through, right? If you have a 50% drop, was it trust issues, beliefs? I mean, family centered issues, educational? Were they not educated on the outcomes? So that right there, when you say future based, I mean, that to me is that's an impressive population that you had access to, and that would be a really great topic to delve deeper into.
The other thing going along with that I was thinking about is language, right? And I mean, we know that we don't do a good enough job. I'm sure neighborhood health does because their population is so largely Hispanic, but there's a lot of, when we talk about access or inequities in access, like not having interpreters and not using interpreters appropriately, there's, for the regular person, it just seems like there are so many things that need to align for you to feel confident about scheduling the colonoscopy. So I wonder if that is a barrier.
Yeah, and to that point, if you were going to explore it further, you are correct. So neighborhood health, at least one of their sites that I know of, they will only hire clinicians who speak Spanish because they have such a high portion of patients who exclusively speak Spanish. And now you're referring them to an institution that does not do that at all, right? And so even the phone call, like, can someone speak to them on the phone in their preferred language, right? Or do they do the things they need to do to translate that for you, which I don't know.
I have more of a sort of publication process question.
Yes.
So Nathan has her hand right.
Well, mine is sort of, it's a separate question, maybe related to that. I'm curious. So you said at the beginning that, when Tatiana had this revelation, that the neighborhood health, it just so happened that they were interested in this, right? And I'm just curious, like, what the conversations were like about, hey, I'm a resident from GW and I wanna look at this data and I'm interested in doing this. Yeah, you talked about the data sharing, but in addition to sort of data use agreements, like, how did, who came up with the variables that you were gonna look at? I mean, you discovered a lot of information that, the clinic may or may not have wanted to know, and I'm just kind of curious, like, what that process was like.
Yeah, and I can give you the up and the downsides to all that stuff. So I just skipped the lessons learned because some of them are what we're gonna say, right? So one was we were partnering with people who were not used to like data in a research way. And I was also supervising trainees who were not so skilled at that either, right? And so when you are supervising trainees, remember that they are not so skilled. And if they are working with a community partner who might just freely email them data and you're like, oh, and I call it, right? They need you to step in and tell them when things are or not appropriate because they don't know that. So we were fortunate that the preceptor who they had worked with at the clinic was actually interested, and it was the person who said like, oh, actually, we're talking about this right now. This would probably be helpful for us to have that. So she was interested enough words. So we had a physician from there who was interested. The main people who we actually, and we spoke with her obviously about what variables she thought. The people who got really into it and really wanted to talk to us is with the social workers there. They had great, very involved social workers. Turns out there, if you fill out this financial assistance paperwork, social worker actually helps you fill it out. So they were quite aware of like, did people fill it out? When was it sent in? It is all documented because they do it with them to do that process. So they actually, we basically interviewed them of like, what do they think the barriers are? Obviously, we started with literature search in general, what are reported as the barriers, but with their kind of social work and physician input of like, what do they see as perceived barriers to make us think of like, what are the other things that we should look at and find? It started out that it was great timing because they were interested. And what I will just say is research is slow. It's slower if you're trying to share data outside of your institution, right? And so this was my first experience with trying to get access to data that was not publicly available and was not my own institution's data, right? So it involved actually having a data use agreement. So it was my first time working with the Office of Research Integrity. They were fabulous. They were super helpful. And this takes a long time. So we needed to have a legal agreement between GW and Neighborhood Health, between GW and Inova, and between GW and UVA to do this study. And it was the moment that I made that phone call that I was like, oh my God, how bad does Tati want to do this study? Because that is going to be a bear, right? To just do that. So that took a while to even just get that groundwork laid. We then discovered as we were in the IRB process, so you can use an IRB that is the main IRB who then the others would rely on, right? It could be a relying IRB, but Inova did not want to rely on our IRB. That was just their own IRB's decision. So we had to go through GW IRB, the UVA IRB relied on it, but had to go through their process for reliance. And then Inova said separately, we need to do our own separate IRB review, which was in fact, I think, more thorough than GW's. And turned out in their process, they needed a faculty member to head that up. And I had been working with a fellow who was there. So we had to get his program director to agree to be the PI on that IRB. So suffice it to say, like, this added a lot of delay in time before we could do it. And sadly, by the time we finished, oh, they sure did. They all graduated on me, guys. Every single one of these people graduated on me. I was the only one left. But the first person who graduated was Tatiana. And then I realized, oh my God, we've now taken all the hours to lay this groundwork. And I need someone who has access to this electronic health record, right? Because we didn't. The convenience was we found someone who worked at each institution, so we didn't have to get the paperwork to get someone else access. So conveniently, we had one resident the year after Tatiana who was at Neighborhood Health, and I was like, ooh, he better say yes when I ask him this question, right? Because I'm gonna need him to participate in this study. And if he had said no, that would have just tanked it. Yeah, would have just tanked it because I had nobody else who had access. So that's one challenge in terms of time with the trainees is they will leave and you don't leave. So can you really carry
Say it louder, Jill.
Yeah, no, it's totally true. And this is not my first time that happened to me, where they graduated and I did not. And you're like, woo, now it's just become Jill's project, right? That she has to carry the finish line.
I caution you against students and residents and fellows
As
driving the project, right? You gotta love it
Absolutely.
just as much
You
as
gotta
they
love it,
do.
because when they graduate, they're like, NRC's been real. No, we just got the data, it's great, done. So that's time. But the other impact that it had was neighborhood health had already like done their like PDSA cycle that they wanted to do about colon cancer screening. So by the time we gave them the data, they were like, oh, that's so interesting. We're like not thinking about colon cancer screening right now. So it also made it less convenient or less useful data for the group that we were working to, unfortunately, because we were on this research timeline that got really held up by the fact that it was multi-institutional compared to like looking at our own
QI.
Yeah, QI timeline.
I'm just curious though, like, when you're thinking about something like this, right, and again, you're partnering with an organization and you're sort of like coming in with a question and then doing the research, like in anticipating the fact that you might discover things that are like, don't shed such a favorable light on what is sort of going on, like, do you preempt that and talk about like, well, what is our responsibility in terms of like how we're going to partner with you and kind of like in future questions or future studies or interventions, like I can just imagine, it's just like, yeah, I don't know, I'm curious, like how do people approach that?
So
I think that's an important conversation. It's a little bit honestly similar to like who controls the research data in any kind of study, like is the funder controlling the research data, or will they permit you to publish that information, right? And this obviously isn't a funder, but a similar kind of like, is there a conflict that someone's going to suddenly say, oh, we don't want you to let that information out because it makes us look bad,
Right.
In doing that. So having the upfront conversation that like, hey, we are applying to the IRB because we would try to publish this, I think is important, so they know that. And what you don't want is a community partner who you're trying to build trust with and they give you data and you did not tell them that was going to be a potential outcome of the data. So we from the very beginning said we would be both giving you this data and information if it's useful to you, and if we find anything significant, we'd seek to publish it too, so that they could say no to that, because I think you do need to let them say no, right, to that question. And then the other is, in theory, things should be they should be de-identified in what you publish. That's different from saying you can't figure it out, right? You may be able, in fact, to figure it out, but you do de-identify at least. Sorry, go ahead, Dr. Nesbitt.
No, I find like with some of the community partners, like we have community health centers that are like chomping at the bit to have us come in and bring in our faculty and our students to help them look at their data and go beyond QI or do more advanced QI and population health analytics, and they understand where academic center and our faculty are going to want to publish. And part of their interest in doing it is because they want to get better, which implies that things are not going well, right? And they'll have their list of like, these are the areas where we know we need to get better. And most of them are looking at the data, they're looking at endpoints, right? Their patients are continuing to churn and continue to have these outcomes, or showing up in emergency departments where we don't want them to. So they may have these endpoints of, high mortality rates and high ER rates, but they don't know what the process measures are that they need to be following, or what the clinical improvement processes are that they need to have in place. And they're really looking for you to come in and help them sort of solve that, right? So while there may be moments of healthy tensions, I don't expect that they are looking to avoid that. The second piece is, like, as Jill mentioned in the publication, neighborhood health is never mentioned. They're referred to as the community health center, and that's extremely common in the publications. What you usually see is that the authors of the publication are usually mentioned by their current institution. So you will usually see that some folks who have moved on are using their current institution and not necessarily where they were when they were doing the work. And then there's the ability to do attribution or a thank you to people who have allowed you to come in and use their data, or who provided you some type of administrative support. My question, which might be, I don't know, Summer, it's 5:05, might be the last question, is you submitted for publication in January and it was accepted in February. Did you all have to do any rewrites?
So thank you for saying that, because I did want to include this slide, because I think it's important that I think not enough people are like, here's what it really looks like, right? So we initially submitted as a research brief. So again, the recognizing there's gonna be a small amount of real estate that you might give us in a journal, to American Journal of Preventive Medicine. That was definitely a stretch journal for us if we knew it, but we were like, let's just try and see. They declined us without a single comment, right? So that's at least a quick decline, right, when you get that back. Then we tried for Journal of Community Health. They also declined us. Then we did Journal of Healthcare for the Poor and Underserved as original research. And interestingly, reviewer number 1 and 2 really liked it. And they gave us like some small little things. Reviewer 3 said this manuscript appears to be an early draft. It requires a major revision in several significant areas in order to contribute to the CRC screening and follow-up after positive FMBT literature. So just to say, even individual reviewers are gonna give you very different comments, right? But obviously that reviewer, they did not
Thank you.
accept us, right? But I received that. I was like, oh, if only you had stopped at 1 and 2, we could have done, right? We could have published. And then we went to Journal of Gastroenterology and Hepatology, open. And again, this is where too, you need to be reasonable of like, what is your sample size? What is the population and where are the areas of interest? So we initially had started out not necessarily in the GI space, but in the sort of like prevention space, thinking it would be of interest. And then we figured like, well, if that doesn't work out, we might like get to the GI, kind of space.
It makes sense, because the GI journal is like, we need to publish more on like the community health aspect of it. Ooh.
So yes, because it's open access, and so there is an article publication charge, and that is the other, we went from like no article publication charge through like more expensive article publication charge, right, as we did too, and that was just because of our own limitations on the way we'd be able to get funding for that. So I always think that like ask other faculty, because they will tell you like it is rare to get it in your environment. But I will say by the time it got to here, we had like changed it so many times because we had to even change the format and stuff, right? We really got it shortened and stuff. So they really didn't. I think they gave us like a few comments that we were like able to address and do it, but it was pretty quick turnaround by it got to that one. But it went from no comments at all, contradictory comments to that. So.
Thank you so much.
Thank you. I'm sorry that we went over, but thanks,
you.
guys.
That's okay. It was really interesting. I loved it. Thank you. Everyone, please look at the calendar, hold your Wednesdays. It's usually the 4th Wednesday of every month from 4 to 5, except for November and December because of holidays. So we bumped it up.
Donna, push that out.
On the Zoom, of course, yeah.
Well, that's definitely takes some people there.